Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
All right, let's talk about two of the most common heart medications out there, beta blockers and calcium channel blockers. I mean, they're lifesavers for millions of people, but they have this hidden dark side that can turn a regular old pill bottle into a major toxicological emergency. So what actually happens when someone overdoses? Well, these medications can literally bring the entire cardiovascular system to a grinding halt. The heart slows way down, blood pressure just plummets, and the body's most vital functions start to fail. It's a terrifying race against time. So how in the world do doctors fight back? You know, these drugs really are a perfect example of a double-edged sword. They're prescribed every day to control things like high blood pressure, but that very same power they have to regulate the heart is exactly what makes them so incredibly dangerous when the dose is wrong. To really get how to fight the overdose, first we've got to understand what's happening on a cellular level. We need to know exactly how these drugs work, and more importantly, how they can stop a heart cold. It all comes down to the most basic signals that tell your heart to beat. Think of it like this. Beta blockers basically put a block on adrenaline. They're telling the heart's accelerator pedal, hey, ease up. Calcium channel blockers, though, they go straight to the engine itself. They physically stop calcium from getting into the heart and blood vessel cells. And those cells absolutely need calcium to contract. So you've got two different keys, but they both end up turning the same dangerous lock. So it doesn't really matter if you block the adrenaline signal or if you block the calcium that responds to that signal. The end result is the same, a profound, life-threatening state of shock. The heart rate tanks, its contractions get weaker and weaker, and blood pressure just collapses.
Okay, but here's where it gets interesting. There's a twist. Even though the outcome looks pretty similar on the surface, there are these subtle but absolutely critical clues in how a patient looks that help doctors figure out exactly what kind of overdose they're up against.
You'd think all calcium channel blocker overdoses would be the same, but they're not. Some of them, the non-dihydropyridines like verapamil, they hit the heart the hardest. They cause the heart rate to slow down a lot. But others, like imlodipine, go after the blood vessels. They cause them to relax so much that the blood pressure crashes, and sometimes the heart actually speeds up to try and compensate. Two totally different paths to the same disaster.
But out of all the signs and symptoms, there's one clue that rises above all the others. One little number from a blood test that screams to the medical team just how bad this poisoning really is, and it's represented by this number right here.
So what is 2.76? That's the increased odds of death in a verapamil overdose when the patient's blood sugar goes through the roof. But why? Well, it turns out those calcium channels are also essential for your pancreas to release insulin. So in a CCB overdose, insulin gets blocked, sugar piles up in the blood, and the heart, which is already in a massive crisis, is now being starved of the fuel it desperately needs. That high blood sugar, the hyperglycemia, it isn't just a side effect, it's a direct sign of severe toxicity. So how do you restart a heart when its main on switches are being blocked? Well, the first line of defense is this really clever workaround. Doctors grab a hormone called glucagon and repurpose it as a sort of temporary bypass key for the heart. Here's the genius of it. Glucagon doesn't even try to use the blocked pathways. It binds to its own, totally separate receptors on the heart cells. This creates a whole new signal inside the cell which essentially bypasses the whole problem. It's like hot wiring a car. You're creating a brand new signal that tells the heart, hey, get more calcium in here and let's get beating again. Now, you don't just dump this stuff in. There's a real strategy here. It starts with a big initial IV push, a bolus. If the patient responds to that, doctors immediately start a continuous drip at that same hourly dose. They have to do this because glucagon works fast, but it also wears off really fast. But it's really important to remember that glucagon is a bridge. It's a fast-acting, temporary fix that's absolutely crucial for stabilizing the patient. It buys the medical team precious time while they get ready to bring out the ultimate weapon. And that definitive therapy, it might really surprise you. It's insulin. And we're talking about massive, massive doses. But in this fight, insulin's job has nothing to do with blood sugar. Its job is to rescue the heart from a state of total energy collapse. This is called high-dose or euglycemic insulin therapy. Euglycemic is just a fancy way of saying normal blood sugar. It sounds crazy, right? You're giving these enormous doses of insulin to save the heart, but at the exact same time, you're running an IV drip of sugar or dextrose to make sure the patient's blood sugar doesn't crash to dangerously low levels. You see, calcium channel blockers wage a two-front war on the body's energy system. First, like we said, they stop the pancreas from releasing insulin. But second, they actually make the heart cells resistant to whatever little insulin is still floating around. So what's the result? The heart is in shock, and it's starving for fuel.
And that is exactly why high-dose insulin is so incredibly powerful. It's like a super fuel delivery system. First, it just overwhelms that insulin resistance and forces glucose into those starving heart cells. Second, it's also a vasodilator, which means it helps relax the blood vessels and takes a huge strain off the failing heart. And third, it actually improves the way the heart uses calcium, leading to stronger, more effective beats. It's a three-pronged rescue mission. But all that power comes with some serious peril. The doses are just huge. We're talking up to 10 units per kilogram per hour, and sometimes even more. This requires an unbelievable amount of monitoring. We're talking blood sugar checks every 10 to 15 minutes at the beginning. And since insulin also drives potassium into cells, potassium levels can just plummet, which could cause a fatal heart rhythm problem. It's a true high-wire act. So, the order of operations here is absolutely critical. Glucagon always comes first. It's the fast-acting, immediate intervention you need to stabilize things. If that's not enough, or the response isn't good enough, that's when the team transitions to high-dose insulin, the more powerful, more definitive, but also way more complex second-line therapy. Now, in the most severe cases, even glucagon and insulin might not be enough to turn the tide. And this is where doctors have to pull out all the stops, using last resort therapies in a truly delicate balancing act to save a life.
This arsenal has a few other fascinating tools. There are things called phosphodiesterase inhibitors, which kind of work like glucagon, but the evidence is a little shaky. Then there's methylene blue, which can help bring blood pressure back up. And then there's maybe the weirdest one, intravenous lipid emulsion. It's literally a bag of IV fats, and the theory is that it creates a lipid sink in the blood that just soaks the drug right out of the body's tissues. So, to wrap this all up, the battle against a beta blocker or calcium channel blocker overdose isn't about finding one single magic bullet. It's an aggressive, multi-layered strategy. It starts with just basic supportive care, but then moves really quickly to key antidotes like glucagon for that quick stabilization and then high-dose insulin for the definitive rescue, all while keeping several last-ditch options in reserve. And all of this brings us to one final big question. These treatments are incredibly powerful, there's no doubt about it, but they're also incredibly complex and dangerous. So the real challenge for doctors in the future is how to refine these protocols, how to get better at predicting which patient needs which therapy, and how to make this intense, high-stakes race against time just a little bit safer.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.